Hello buddy, Senior Engineer MBA and Investor, and in today's video I have a special video to show you guys. This is an interview that happened on the 1st December of 2021. That's about 7 days ago last week. It was basically an interview where CRISPR Therapeutics CEO Dr. Sam spoke on the Evercore ISI conference. A bunch of other companies came about, including Caribou Biosciences, which I'll make a video in tomorrow's video. But today's video, I want to talk about this interview that happened. I will speed this video up 2 times almost the speed just because of time constraint here, and I'll be pausing the video here and there to give my thoughts, some hidden gems in there. And basically, if you've read the video title, this is breaking news, but I'll talk about it all as we play the video. So let's go about it.
Yeah, thanks for having us, Lisa. And it's always fun to be at this conference, which we've been doing for the last 4 years. I think it's a space that's evolving quite rapidly with CRISPR. I think when you back in the early '80s, when you saw companies go after antibodies, you had many different strategies that each company espoused, and that was one of the big differences between success and failure is the way you build and shape your portfolio. Broadly early on there was this question of ex vivo versus in vivo, and the two different approaches to use CRISPR, and we decided we wanted to play in both areas. The question was how do you prioritize and how do you move things first versus second, and in terms of our strategy, what we want to do is we operate in franchises, and we want to actually make businesses that actually become self-sustaining. We don't want to be a company that's constantly diluting and raising funds. And with that sort of notion, what we've done is picked sickle cell and thalassemia, where there's tremendous data so far. It can be transformative for patients suffering from those diseases, and that's something that we could file on. Our goal is to file end of next year. So that becomes its own standalone franchise where we continue to obviously make improvements and develop next gen versions of it. But there's that one sort of thematic bet, which is sickle is the oldest known rare disease based on a single mutation in the world. We can cure it ex vivo using CRISPR, and that makes sense to us. I think the next two bets, the other main three franchises for us, one is smart cells in oncology, regenerative medicine, basically engineered cells for regenerating organs, and in vivo approaches where we go after rare and common diseases by delivering CRISPR into the body directly. And each of those have their different merits and demerits and risks, but it makes sense from a company perspective to expend private resources and build competency in smart cells and cancer. If you ask me the big picture question, 60 years after we declared the modern born cancer, what is the most promising way of generative cancers or curing cancers? I would argue it's smart cells. People will say, well, not there yet. There's generally a market sort of view that's of smart cells where it's not as favorable as it was a year ago or maybe 2 years ago. But these things turn around. They go in cycles, and there's always ups and downs. But fundamental bet is smart engineered cells versus cancer. I think we're going to get there, and that's going to be the best way to cure cancers. And then the next bet is there are several common diseases like diabetes we can cure by essentially recreating organs. We've lived in a world where organ transplantation mainly has been based on pig organs or organs from cadavers, which are very difficult to obtain. Obviously, there's live donors like kidney donors and stuff like that. But if you can create organs, whether it's kidneys, liver, pancreas, there's a whole swath of diseases we can cure, and that's a very powerful platform. And finally, in vivo CRISPR is working, and that's something that's a big focus for us. And there's at least half a dozen indications we're working on there with both AAV and LNP approaches. So if everything goes well for us, I think we just this year activated our third franchise, which is type 1 diabetes, and that's in the clinic now. We've taken the first one to a point of maturity where we can file BLA. The second franchise is starting clinical trials. The third franchise is going into the clinic, and we'll soon be in the clinic with in vivo approaches. I think that sort of continuum made sense to us from a de-risking standpoint for the platform, but also made sense from a business standpoint in terms of our investments and thinking about the return on invested capital over the long run, with the goal of becoming a $7,500 billion company in the next 5 to 7 years, assuming these bets play off.
So a couple of points here. First of all, I don't know if you guys caught that towards the end here. He just mentioned basically 75 to 100 billion dollars market cap company in 5 to 7 years. If you take their current valuation, at least from when the video was made here in the December 1st, that's about 20 times from their current valuation. I love that prediction. But I'll take that as a grain of salt because Dr. Sam has made comments about earlier this year, actually expecting CRISPR Therapeutics to be worth $25 billion by the end of this year. Obviously, that has not come to fruition and most likely will not, as we have like 3 weeks left of this year. But I really love how he distinguished between three franchises within the company, right? The company itself, CRISPR Therapeutics, three franchises, right? First one, which we've talked many, many times about, CTX001, sickle cell disease, beta thalassemia. And then you have the second franchise, which is more with the oncology program, the regenerative medicine, basically their CAR T cells and so on, all those programs there. And then you have the third franchise, which is for organs, right? Specifically, in example, type 1 diabetes. I really love how he was able to distinguish between three franchises within the company umbrella. I think this is the first time he's been describing the company like that. I think the vision of this company has been changing, shifting, especially with a lot of criticism from public markets, especially when it comes to base editing and in vivo. And he's mentioned in vivo in here, but we'll see shortly why base editing matters. So let's keep playing.
So just let's go through the portfolio. We started at the beginning with XV, but just a couple questions here and there. How soon are you going to file at the end of next year? I know you're trying to file as soon as possible, and I'm not quite sure exactly what FDA wants in terms of like number of patients and duration of follow-up and all that kind of stuff. Is this still a moving target, or has it been solidified?
Yeah, I mean, both Vertex and us have said our goal is to file by the end of next year. And with the regulators, given the RMAT designation, we have a continuous set of meetings with them. They've been very supportive. We are converging on all the requirements, whether it's clinical or non-clinical. On the clinical side, really the final piece of convergence is around exactly laying out the amount of follow-up that we need for the patients, and how many patients are in the safety cohort. On the non-clinical side, I think there's a whole host of requirements on the CMC front, which we feel confident we can get to. And I think we're getting very close to getting to that sort of convergence point with the regulators. But our goal is to try and file by the end of next year.
Okay, great. I have a couple commercial questions, so I'll just try to frame it up in one. Like, first of all, is access. And access, I mean, like, what's the capacity in the system? This is a very involved procedure. As I look at, stem cell transplant, there's like 21,000 done per year in the U.S. So what's the capacity, and what's it? Are you concerned about patient access at all? Clearly it looks like it's going to be a relatively expensive medicine. There's no denying the medical benefit is huge, but I wonder about access and capacity on one hand, and then on the other hand, there's a lot of competition coming behind you. Are there barriers there that are natural? I mean, this is a hospital-based product. Should we think about that being a key barrier as you're first to market? How do you kind of see the competitive landscape evolving? So two questions there, but it really circles around.
Absolutely. I think the way the commercial side of this, the way you sell a drug or bring it to market is different from pills or antibodies. You're essentially bringing a procedure to patients. It's more in the medical device realm to a certain extent of how you bring to market, how you ensure the sort of experience for the patient and the physician as they go through this procedure. And obviously the outcomes are the most important. But as you think about it, there is capacity in the system. I think I don't think we're saying that we're going to have 20,000 procedures in the year we launch, right? I think this is much smaller numbers initially, but you'll have a lot of growth over time, because as people see get more experience with procedures, you'll see more physicians wanting to do it and more patients wanting to take a procedure. Similar to some of the more complicated medical procedures, like the mitral valves or the valves that you insert through the portal vein or through hepatic arteries, right? So I think you have non-invasive procedures for complicated procedures like heart procedures, and it took a while for the growth, for every physician to accept that. Once they're trained in that, you saw a lot more volume. And there's also a second factor: there's a great sense of loyalty to what they trained on. And I think once you start getting used to working with Vertex and us from a hospital and from a provider standpoint, I think it becomes easier to stick with what you have, especially given the data we have. I think access, is always a consideration. I think for a therapy like this, it's going to be high price in the beginning because it's very expensive to make these cells. There's lots of supply chain involved, but the pharmacoeconomics case is very clear. For not to mention the value you bring to these patients, especially patients that have been sort of ignored and patient population that's mainly underserved when you think about the last 50 years of drug discovery and drug development. And I think both sides of the aisle are going to come together, I think, to enable this from a government standpoint, and the system will support something as revolutionary and transformative as this. So we're quite confident. Obviously, Vertex has a lot of experience in bringing these medicines to market, and we think this is something that the street probably underappreciates, the kind of value that this therapy can bring to patients and the value that can accrue to the companies that are commercializing it. Last piece around the competition, I think obviously once you see the data and you see good results, you end up with a lot of fast follower type concepts. And I think it's very difficult. You saw that with biologics in general. I think it's not that easy, especially with the bar that we've set to be a fast follower, given that this is not a pill that's dispensed in the pharmacy. So I think you're going to see market share split that's similar to, again, medical devices where if you have an early mover advantage, I think it's both Bluebird and us will have that advantage in market around the market shares.
So lots of comments here about Vertex, their partnership there, lots of confidence about Vertex to bring this commercial. Dr. Sam didn't really mention a specific number here, and I think the interviewer was sort of looking for a specific ballpark number. He did say it's going to be much less than 20,000 procedures basically a year, but that number will slowly increase. I believe the number we've talked about in the past, and that has been mentioned by Dr. Sam, is about 1,000 patients. This is about for CKX001. I love the comments about competition. Let's keep the video rolling.
Let's turn to smart cells and cancer. You had a great sort of first allogeneic CAR T against CD19, which is awesome. But the market seemed a bit disappointed. I feel like maybe people wanted to see a little more efficacy. I guess based on what you're seeing, where do you see a product like this fitting in? And again, kind of the question about where it fits in over the long term, because we did count about 100 programs. Kind of working on CD19 is just incredible, the proliferation. So where do you see this kind of like fitting in?
Yeah, I think the market has a different way of looking at some of these data. And I think depending on the sentiment out there, you end up with rose-colored glasses or glasses that say all data is bad. I think for me, what was really interesting was that a couple weeks after data disclosure, 2 weeks after data disclosure, we got the RMAT designation from the FDA. And the FDA looking at all the data holistically in making their decisions, and they don't take the RMAT designation lightly. Similarly, we've gotten a lot of support from the European regulators around our program. And the issue is, I think right now, a lot of investors are looking at allogeneic data with the same lens that they use to look at autologous cell therapies and data. And that's not the right lens. I think if one of the patients that were in our study who achieved the durable benefit was saying, gosh, I came into the study thinking, I have cancer, I've gone through all these therapies, I'm going to lose my hair, it's going to be awful with GI effects and skin rashes and everything else I have to deal with. And that came in, this is a relatively benign therapy, and my cancer's gone. And I think that kind of profile where you have a very safe drug, and it's very clear that if you have a reasonable tumor burden, but where it's not very high and it's not in progression mode, that you can achieve cures. People kind of forget in the moment what's been achieved here. For the last 25 years, and I was at the University of Washington where there's a lot of work being done 20 years ago around achieving universal cells. And with a single dose of an allogeneic CAR T, we've achieved a complete remission, durable complete remission in a patient. And that's a huge achievement for the field, which in the moment is kind of lost because you're sitting there, with complicated Excel models comparing data X and data Y. And, again, 3 years ago when we started the program, I was sitting having a cup of coffee at JP Morgan with a pharma CEO who said, if you get durable response in allogeneic CAR T, that's a Nobel Prize winning endeavor, or you may take a couple of Nobel Prizes, in fact, to get to that point. And here we are. We've shown that you can do durable complete remissions with a single dose of allogeneic CAR T. But I recognize what questions are coming up, which is there's a lot of competition. There are many different cell therapies out there. There are other modalities like bispecifics that are improving. There's autologous that continues to have good data. And we recognize that. But if you can establish a safe, easy to dose, convenient drug and get it approved, it's only going to grow. And when Tagrisso first got approved, the market was a market. The market was underestimated by an order of magnitude. And I think that's the way we see this. We see tremendous promise in the CD19 therapy, in spite of the competition, because we're ahead and we continue to make improvements and grow into a drug that can be more than $1 billion drug. And so we're continuing to invest in our smart cell, engineered cells thesis. We have our own manufacturing facility now. We're going to make these CAR Ts, and I think you'll continue to see good data, improving data over time as you put more of these therapies into clinical trials.
So a couple of great tidbits here. First of all, I love how the CEO here, Dr. Sam, I love how he always refers to the public markets, the street, the investors. He's aware of everything outside the company, how people are reacting to the company, especially in the recent months. He's making these comments like, I don't, quote unquote, I don't think, like he's using words like underrated. Like he's using keywords there, and I think you have to be an observer to really catch that, especially that anecdotal experience where he explains that he had dinner. He was having a lunch or a coffee, whatever, with a big pharma company CEO, and they said if you get some sort of durability with your program, you should win a Nobel Prize. And 3 years later, boom, they proved in their data. In fact, right after the data, that's what he mentioned. 2 weeks after, they got designation from the FDA in US. They already have some sort of designation in Europe. So I think you have to understand the dynamics here. You have to understand what Dr. Sam is mentioning here. It's more than just explaining that there's a future about this program. It's more than that. It's actually insisting that public investors, big pharma companies are completely missing out the story on what they're doing with their CAR T cells program, especially with their latest data. And the fact that he says about competition, he says more programs, better data, it's better for everybody. It's not a lose-lose situation. It will eventually be a win-win situation. And when it comes to CRISPR therapeutics, I truly believe that. So let's keep the video rolling.
Is a read-through from CTX 110 to 120 with the BCMA CAR T? Be curious on your thoughts of read-through from this program to the next.
But the main
value of a platform in a way.
Yeah, the main takeaway or lesson for us is you can redose safely, and a consolidation dose can make the data better. I think there's this ratio E to T, effector to tumor ratio. If you have more effector cells or more CAR Ts compared to tumor, surprise, surprise, the tumor is taken out. And if there's more tumor than the CAR Ts can take out, and the CAR Ts get exhausted, then they're not completely eliminated. So with that notion in mind, if you have the first dose and you reduce the tumor burden significantly, and then you have come with a second consolidation dose, I think you are going to get more patients into complete remission and durable complete remission, hopefully. So that's the key carryover for us. There are a lot of other lessons. We have Gen 2 and Gen 3 versions of our CAR Ts that we're already working on. I think in those Gen 2, Gen 3 versions, we have several more edits. We have edits against exhaustion, edits for persistence, and they're bound to, more very likely to be better than the first gen. So I think it's only going to get better over time as we learn from the first trials.
So catch that first gen, second gen, of third gen of CAR T. Catch those keywords, very important. They keep iterating on those programs. Again, that's the second franchise that we referenced earlier. So let's keep the roll.
What do you think about how this moves to kind of CAR NK way?
Yeah, the CAR NKs are promising. Obviously, we have our Nkarta collaboration where we're doing NK cells, CAR NK cells. And I think, our immune system uses all these redundant mechanisms to kill pathogens, right? If you get an infection, we have T cells, antibodies, and NK cells all come into play. So why not use more than one modality? And especially if they're safe. So I think with the safety we established with our allogeneic CAR T and the fact that NK cells can be relatively safe, it lends itself to a combination, essentially. And I think over time, I think you're going to see both CAR Ts and CAR NKs come into play relative to as a better combination than, say, CAR NKs plus antibodies and other complicated regimens.
So I'm going to pause this really quickly and just mention, notice how many times Dr. Sam is mentioning the word safe and safety. Just notice that these are types of keywords you want to listen to. These are types of, it may very well be that he's well spoken and he's been trained to give many of these conferences and interviews. Obviously, he is a CEO of a $1 billion market cap company, few billions at this point. So he's well aware. He has a lot of experience under his belt, especially when it comes to healthcare/genomics. But I just love the idea that he's truly focused on safety. This is to all the quote unquote haters. You can say whatever you want about this company, about the CEO, about what they're doing, and it's the first gen of CRISPR, but it always boils down to safety, right? Efficiency, safety, data. It's not about looking cool. It's not about looking great. It's not about attracting more investors to put in more money so that they can cash out their internal shareholders or employees, stock-based compensation. It's not about that. It's about safety data. I love that. Again, it could just be a facade. It could just be him making it look good. But I'm picking on those keywords. So let's keep the video rolling here.
we don't have much time to talk about your CD70, but that's coming soon, and we'll look forward to updates there in solid tumors. That'll be really interesting to see. Type 1 diabetes, I'm excited about that. And what you just started clinical development, kind of what should we expect to see as this kind of first patch of data unfolds from this program? What are you hoping to learn?
Yeah, we're very excited. I think our goal was to get into the clinic this year. We've successfully done that with the Health Canada approval. We want to start dosing patients soon. And the key test for me is, I think, looking at the cells a few months out to see what the edits we've done for making them stealth. What is the contribution of that? Are these cells truly stealth? Are they protected from the host immune system? As in these trials, we're not immunosuppressing the patients. So if we can get to insulin production, but make sure that the cells are stealth, that's a big win. I think the latter part is more important for us because the insulin production in response to glucose we can tune. We can always change how much insulin production there is with engineering. But I think with the stealth aspect, we made a bet with the 4 edits that we have in the cell. How much does that protect these cells from the immune system? And I think that'll be really tough. I think we already see some proof of concept with the Vertex data on one patient of this notion of engineered cell. And I think this field is going to start burgeoning soon.
It's awesome. Where are you putting the cells, by the way?
So the cells are put in a device, and the device is implanted typically in the flanks of the patient. But depending on the patient, you put it in different places, but typically in the flank, because you then want some vasculature and you want some perfusion of those devices.
So just as we wrap here, Sam, can you just walk us through 2022 from CRISPR's perspective? What are kind of some of the key, kind of value inflection points from your perspective for the company?
We're very excited about 2022. I think we've achieved quite a bit in 2021. I think stock market aside and share price, that's one dimension. But I think from a fundamental standpoint, if you ask me, sitting here today versus last November, last December, we've achieved quite a bit. We brought our type 1 diabetes program to the clinic. We're ready to kick off our pivotal trial with CD19. We're getting that much closer to our BLA filing with 001, and we have a number of in vivo programs that have moved closer. Not to mention all the platform improvements we've done. We have our own base editors, our own insertion editors, new donor templates, small Cas9. We made all this progress on all those fronts. And for 2022, I think we'll be continuing set of catalysts. I think we have our CD19 data, our 001 data, which is a continuation of the data we've shown you. But then, if CAR T start working in solid tumors, that's an incredible advance. I think in type 1 diabetes, obviously, I think it's a pretty significant value driver for us if that starts working. Not to mention bringing some in vivo programs to the clinic at some point.
So guys, I'm gonna end this video like this because this is pretty much what I wanted to boil this video out. These last 2 minutes of that video was like so golden. I can replay it if you guys really want me to. I'll put the link here at the bottom here in the comment section for you to take a look at the webcast. But really, he just mentioned they have their own base editor, right? And that there was a whole thread about this yesterday, and we talked about how base editing, you could do whatever you want in your labs, but when it comes to IND, when it comes to FDA, this is where you're gonna run into issues with, especially with Beam. That's obviously in base editing. But the fact that he just mentioned we have our own base editing, right? And I think that's breaking news. I think he has mentioned that in the past in an interview, but this, with the way he said it here, to me, solidified that they have their own base editor. Now, why they haven't filed for a program for it, why they haven't filed for IND, I think this is a separate topic. I don't think it's necessarily correlated. I think, and I was saying that yesterday, and again, I think we'll make a whole video on the past, the present, the future of base editing, especially after Biotech's comments there yesterday. Biotech 2K1, the user we've covered in this channel, and he or she will be making a thread shortly for us to take a look at about base editing, the past, the present, and hopefully the future. And my only guess right now is the reason why CRISPR Therapeutics has not filed for IND for a base editing program, for example, unlike NTLA, who has done so, or at least they've set out a PR for it, is because CRISPR Therapeutics, they're so focused right now on their three franchises that we just talked about, right? CTX001, the CAR T cells, and of course, we're talking about type 1 diabetes that they just filed. And he just mentioned that since last year, lots of changes have happened in this company, especially when it comes to the other everything else than CTX001, right? Including CTX001 with more patients dosed, with more safety data, more efficient data. And to me, it's actually riskier for them to do so, because imagine a scenario where they mess up on their data for phase 1 for base editing program, right? Because they wanted to rush it, or because they just wanted to attract public investors. This will destroy their company's valuation, despite them advancing forward with their current three franchise that we just mentioned again in this video. So I think they have a lot to lose here, and I think they want to sort of stick to their guns here and really get their mission across, right? Getting the first CRISPR drug FDA approved. I actually think once FDA is close to approving CTX001, once they get further with their CAR T cell programs, and then once type 1 diabetes gets rolling in Health Canada, from Health Canada in Canada, I think this is when we'll see advancements towards the other edits, including base editing. So hopefully you guys appreciate this video. I'll end this video like this. It is a long video, so hopefully you guys appreciated it. I'm gonna mentioned to you guys that you can find this interview in the comments below. Let me know what you guys think about this interview. Let me know what you guys think. Tomorrow's video will be on the Caribou Biosciences and the same webcast conference, but with Rachel Harris, the legendary Rachel Harris. So thank you so much for watching. Don't forget to like, subscribe. I'll see you tomorrow. Thank you.